Welcome to The Explainer. Today, we're diving headfirst into the high-stakes world of emergency medicine. We're going to talk about a class of drugs that are absolutely critical for saving lives: vasopressors. These are the go-to tools when the clock is ticking and every single second counts. So picture this. You're in an ER. The alarms are going off. You hear a doctor say, a patient is crashing. What that usually means is their blood pressure is plummeting and fast. In that moment, the entire medical team is focused on solving one single urgent problem. How do we get that pressure back up right now? And really, it all comes down to pressure. Our blood pressure is literally the force that's pushing life-giving, oxygen-rich blood to all our vital organs. Without that push, our most important systems, our brain, our heart, you name it, they just can't get the fuel they need to keep running. So when that pressure fails, say in something like septic shock or a full-blown cardiac arrest, it's a massive critical threat. The brain, the heart, the kidneys, they all start to go dark. The body is in an absolute state of crisis, and it needs help immediately.
Okay, so how do doctors actually fight back when the whole system is failing? Well, they reach into an emergency toolkit of some really powerful drugs. And these drugs are designed to do one thing incredibly well: squeeze the system.
They're called vasopressors. And honestly, the name tells you pretty much everything you need to know. Vaso is for your blood vessels, and pressors, well, they press. They are literally vessel pressors built to get a patient's blood pressure up in a hurry. Now this is the best way to visualize it. Think about squeezing a toothpaste bottle. By constricting the blood vessels out in your arms and legs, a process called vasoconstriction, these drugs force all that blood back toward the center of the body, making sure your vital organs get the oxygen they are starving for. But how do these drugs know what to squeeze and how hard? It's not just random. They work by targeting this really sophisticated built-in control panel that we all have. It's made up of things called alpha and beta receptors. Think of them like little buttons. So, the first button on our panel is the alpha-1 receptor. And here's a fantastic way to remember it. Think of an anaconda. Alpha-1 gives the blood vessels this incredibly powerful squeeze, just like an anaconda, clamping down and jacking up that pressure. Next up, we've got beta-1. This memory trick is even easier. You have one heart, right? So beta-1 mainly affects the heart. It hits the gas, increasing both how fast the heart is beating and how hard it's squeezing. It just pumps more blood with every single beat. And our last main button is beta-2. You guessed it, the trick continues. You have two lungs, so beta-2 does its big work there. But here's the twist. Unlike alpha-1's squeeze, beta-2 actually causes things to relax. It opens up the airways, and it even dilates some blood vessels, which is a really important balancing act. Okay, so we've got our control panel down. Alpha-1 for squeezing, beta-1 for the heart, and beta-2 for relaxing. Now let's meet the specialized team of drugs that doctors use to actually push all these buttons. The main players you'll hear about are epinephrine, norepinephrine, dopamine, and vasopressin. And here is the absolute key takeaway. They all raise blood pressure, sure, but they do not all push the same buttons. Each one has its own unique profile, its own specialty. This chart shows you their specialties perfectly. Look at epinephrine. It just slams the alpha-1 squeeze button and the beta-1 heart button. It's an all-out assault. But then look over at norepinephrine. It's almost pure squeeze with very little effect on the heart. And then you've got vasopressin over there, which is a total outlier. It works in a completely different way. See? It's a whole toolbox, not just one hammer. So let's just put the two most common ones side by side. Epinephrine is your all-rounder. It just goes in and hits everything with force. Norepinephrine, on the other hand, is the squeeze specialist. It's the one you call when your main goal is just pure, powerful vasoconstriction. So what does all this mean? Well, the crucial point is that knowing these different drug profiles lets doctors pick the perfect tool for the specific crisis. This isn't a one-size-fits-all situation at all. It's about matching the drug to the emergency. Let's use septic shock as an example. The huge problem here is that a massive infection has made all the blood vessels leaky and wide open, causing a catastrophic drop in pressure. So what's the goal? You need a powerful, system-wide squeeze. And the perfect choice for that job is our squeeze specialist, norepinephrine. Now let's contrast that with cardiac arrest. Here, the heart hasn't just gotten weak, it's completely stopped. The goal isn't just to squeeze vessels. You gotta do everything all at once. You need to restart the heart and squeeze the pipes. And for that all-in-one job, you bring in the all-rounder, epinephrine. So, to wrap it all up, vasopressors aren't some kind of weird magic. They are incredibly powerful, precise tools that work by hijacking the body's own control panel, those alpha and beta receptors, to basically act as a manual override and restore that life-saving blood pressure during a crisis. But here's the final and maybe most important thought. Vasopressors buy time. Precious, life-saving time. They get the patient stable. But what they are not is a cure for what caused the problem in the first place. So the real question is, once that pressure is back up, what's next?